My name is Shruti Katari. I lead industry initiatives for Blue Shield of California, focusing on mission-centered advocacy and policy movement. And I will be your moderator for today. We are going to have our opening remarks from California Pan-Ethnic Health Network. We're very lucky to have the executive director, Kiran Savage Sangwan, to kick us off. And then we'll move into a structured 30-minute panel with Andy Martinez-Patterson, who is the VP of Government Affairs for the California Primary Care Association, Stephen Hardy, who is the CEO of My Sidewalk, Michael Peterson, who is the Health Equity and Health Innovation Lead for Accenture, and Didi Janice, who is the VP of Holistic and Community Health for Blue Shield of California. Without much further ado, I would love to turn it to Kiran for our opening remarks.
Thank you so much. Thank you for having me here today. As was mentioned, my name is Kiran Savage Sangwan. I'm the Executive Director of the California Pan-Ethnic Health Network, or CPEN. I'm really thrilled to be here with you today. Just to say a few words about who we are, CPEN is a multicultural health advocacy organization. We have a commitment to achieving racial justice by eliminating persistent health inequities. And we were founded in 1992 in the wake of the police beating of Rodney King in Los Angeles. And so I think this year has given us a lot to consider in terms of what has changed in our world and in our state, and also what has not changed in the last nearly 30 years, and what we really need to work towards. We at CPEN believe that by building power in communities of color and holding policymakers and systems accountable for eliminating health disparities, we can create healthy, safe, and equitable communities. We do believe that those goals are within our reach. However, what we know is that today communities of color have less access to healthcare, poorer health outcomes, and more exposure to conditions that inhibit rather than produce health. And really, I think, we look at a number of conditions and indicators when we talk about those, but in a really big picture, and I think some of the most alarming statistics, we know that Black men live on average 11 years shorter life than their white counterparts due to primarily preventable environmental and health conditions. Within just the city of Oakland, a Black child born in a low-income neighborhood today will die 15 years younger than a white child born in an affluent neighborhood in the same city. People of color are more likely to self-report poor or fair health and to report discrimination in healthcare. And we also know the social conditions, or I think today being referred to as the social determinants of health, such as residential segregation, barriers to educational attainment, barriers to fair employment, and violence perpetuated by the state via law enforcement, all contribute to the conditions that result in poor health and untimely death. But I do want to emphasize, so does healthcare itself, which is an important thing for us to keep in mind as we go through this conversation. There was a poll put out just at the end of last week by the Kaiser Family Foundation that showed that over half of Black consumers distrust the healthcare system because they believe that it treats Black individuals unfairly. And data shows that this is true. For example, Latino and Black consumers, including children, are less likely to receive pain medications than white patients with the same symptoms. And what we all know sort of goes without saying at this point, but I think important to say anyway, is that COVID-19 has demonstrated the unconscionable impacts of structural racism in both social conditions and in healthcare. Black, Latino, Native American, and Pacific Islander communities are facing high rates of exposure due to employment in both frontline and low-wage jobs, and the lack of a social safety net to support things such as isolation and quarantine when necessary. Moreover, the rates of serious illness and death are borne disparately by the Black community, the culmination of generations of unequal access to and quality of healthcare. But we do certainly see hope and see a path forward here. And I think a really good example, California's blueprint for a safer economy, our plan to reopen as we contain COVID-19, and the recently instituted equity metric give us a clear direction of how truly solvable these problems are, given the political will and resources. And in this case, the state is requiring counties to target their resources to essentially zip codes that have the highest burden of negative impacts of social conditions. So with all this said, and sometimes it feels insurmountable, how do we decide where to start? Which is why I'm so excited about the topic of the panel today, which is data. Data really is a reflection of our values, and what we decide to measure and what we decide to represent drives decision making and drives outcomes. Structural racism and discrimination results in us seeing and developing data which confirms our biases and sometimes missing indicators which might challenge our beliefs. So the question of what defines health or good health has traditionally been decided by systems and institutions, not by people and communities. And so what do we do to flip this so that we can make true change? Well, we need to rethink what we measure. We need to rethink how we measure it, how we tell a story of the data we've collected, and how we define the solutions based on that data. So again, just really thrilled about the panel and the work that's happening here to really look at what we can do with data to drive change and to drive the reduction of health disparities. Because I do believe that addressing the deeply embedded inequities and injustices described just in the last couple of minutes requires a radical reimagining of our institutions and a willingness to engage in shared decision-making for accountable systems. That's one of the reasons why we at CPEN have called upon Governor Newsom to declare racism to be a public health crisis in the state of California, because it is. And it's also why we're so glad to see health systems stepping up to acknowledge and address these injustices through a data-informed lens. So thank you again for having me. I'm really looking forward to hearing from the panelists, and I will turn it back to the organizers.
Dee Dee, Andy, Michael, and Stephen, thank you so much for being here today with us. Super excited about this conversation for many reasons, one of which is that all of you come with a different subject matter expertise, but are equally passionate about this topic. So I thought to kick this panel off, why don't we start with each of you telling us why you're excited about this. So maybe Dee Dee, we can start with you.
Hi. So I think, there's a lot to be excited about, I think, with this work. Data is important. And actually at Blue Shield of California, we think it's imperative to being able to shift from, current state where a lot of organizations are focused on the individual social needs of, members and patients, to being able to, through this shared data set, being able to shift to focusing on social determinants of health. We aren't going to be able to make that shift if we keep making, sort of diluting the impact of what we're doing by sort of, piecemealing it and spreading it around. We also think that by sharing the data openly, we're going to be able to have more concerted action in terms of being able to support policies and to be able to support programming and create programming and interventions that are going to move the needle finally on health outcomes for communities throughout California, and also be able to close the health equity gap. And I think finally what I'm excited about is that, it's not just big healthcare organizations or, large employers who are going to be able to have access to this kind of data, but it's small community-based organizations and community members themselves who can use it to design their own solutions, advocate for and design their own policies, and secure funding for things that they're already doing that's working.
So I'm here. The California Primary Care Association represents community clinics and health centers across the state of California. And health centers were started very much in the embers of the civil rights movement, and seeing that healthcare access and the injustices of the inequities of systemic racism and everything going on. And we have been delivering excellent care in a comprehensive setting for a really long time. But one of the barriers to really delivering or achieving the outcomes that we want are the social determinants of health. And we've long known that, but we really haven't been able to get underneath it. And now having a dashboard that has over almost 100 indicators, and we all know that nobody can do it by themselves. The communities can't do it by themselves. The healthcare provider can't do it by themselves. And the dashboard really brings this opportunity where you can get a whole bunch of stakeholders from the community together and focus and look together to collaborate to do this, because healthcare really, it's been very individual, as Judy just noted, and it's not working. We have to do this together, and the dashboard really provides this phenomenal opportunity to do it together. So I'm really excited to be here to talk about social determinants of health, collaboration, and finally seeing if we can turn the tide on all of these inequities. Thank you.
Awesome. Thank you, Andy. And for folks out there, the dashboard that Andy is referencing is the Neighborhood Health Dashboard, which you will learn more about in just a minute. But Michael, you want to go next?
Hey, good morning, everybody. Thank you. Greetings from Texas, so I'll say howdy. Absolutely thrilled to be here and enjoy, share this conversation. I'm really passionate about it because of my own upbringing, having grown up in poverty, being born in Vietnam, adopted. So I have this like pay it forward DNA inside of me, and I'm absolutely thrilled to be able to be in a firm that helps bring the collaboration that was just mentioned around solving these health inequities. We talk about social factors and we talk about all these things. I've seen them on the front lines when I practice emergency medicine, pediatrics. And in that experience, it didn't matter how hard or how smart or how amazing the technology was, we still failed. And it's this acknowledgement of several things we have to really to be honest about. And I love what was said in the introduction, which is that we still have implicit bias, we still have structural racism. I've heard dads being called baby mama, or are you baby daddy at a delivery? The way we treat people has to change, and we have to acknowledge that. So what I really enjoy is that, you know, taking data, technology, and people and using them as tools to really try and bring the right set of capabilities to really solve a specific use case. And I'm excited to share in these discussions. So thank you for having me.
Yeah, absolutely. And last but definitely not least, Stephen?
Probably least. It's great to be here today, everybody. Really nice to have this opportunity. I'm the CEO of My Sidewalk, where we work to democratize data. We build a platform to bring the power of data science to as many people as possible, particularly though those working to build healthy, thriving communities. I also have an 8-year-old son who's been asked to play his first fantasy football league this fall, and I think it's a pretty good analogy actually for what we're trying to do. He has at his fingertips every possible data science tool and visualization that you could imagine in order to decide who to sit and start this week. And so if we think about using that kind of expertise and data and brain power instead of to just be amusing ourselves on the weekend, but actually to be improving the places where we live, that's really what we're trying to do here. And I'm really optimistic about the progress that we've made collectively over the last couple of years. There's clearly a convergence between community development, city planning, and providing good health in a holistic way that, in conjunction with good data science tools, I think can really make a difference. So it's great to be here today.
Awesome. Well, thank you all. So we know that to make an impact on community health, to truly make an impact on community health, it's a collective effort. And when we take a look at strong collaboration between large healthcare enterprises and community-based organization, there's lots of players within the ecosystem, but I want to focus in on that. Maybe Dee Dee and Michael, can you talk a little bit more about how Blue Shield of California and Accenture, how they're leveraging data to support stronger community engagement and work at that social determinant of health level?
Thank you, Shruti. So we know that about 80% of people's health outcomes are attributable or being driven by social determinants of health. And we also know that in order for us to attack or address those social determinants of health, it is going to take, as Michael pointed out, a system of people, of data, of tools. And one of the things that we're doing at Blue Shield of California is we are building a community health platform that leverages all three and the amazing data science and data from our partners at My Sidewalk to be able to connect people, all across California with the resources, local resources, digital resources, other resources that they need. And we're using community health advocates, people who are part of the communities that they serve, in order to be able to make connections with the community and also to be able to drive a stronger link between community and clinical, right? Because we know that there's emerging evidence that doing that will also further improve health outcomes, reduce inequities, and also lower costs. So we're doing that, plus analyzing what we learn, sharing hopefully what we learn through further stages of this dashboard, but then also making sure that we're talking to the community and checking in with the community, because I think we all know that data is great, but it's not the whole story on any community.
What Dee Dee just shared, it's absolutely the way forward, which is as we think of the racial injustice narrative and the confluence of that with the pandemic, what you have is a time, a moment, and we're here talking about it, but everyone on this call is actually doing something. We're working with our clients, we're working with people. And I love what Dee Dee just said, which is that you can't fly a drone into a zip code and solve social determinants of health. It is hard work and it takes time. You can't do it assuming you know the people you're trying to help. So you have to get on the streets in some ways. And you're using data and technology to help really get you contextualize what question you're trying to solve. So as an example, you can't solve it all. You can't boil the ocean. And as Andy's pointed out, you have to collaborate. If one company thinks they're going to solve this, they're just spinning their wheels and they're going to waste their time. It has to be solved, as we've seen how the pandemic has been solved on sort of organic ways with collaborations that would have never been thought of in the past. You've got Ford Motor Company making ventilators. You've got FedEx, Kroger, and Providence Health in Seattle trying to deliver meals to people. So you have these really bespoke solutions that are trying to solve it. So how do we take that energy and that momentum and drive it forward? And so one example is in Ohio, using data as was described. Data is really, just like I said, a tool. It's an enabler. But what you really need to do is have data and the ability for people to make decisions to share the data. So you're going to have multiple agencies, multiple things that can do that. And when I said about use case, instead of boiling the ocean, you really have to ask a very specific question. So in Ohio, we did some infant mortality work that was a pure data science. It wasn't a descriptive analytics process. It was actually getting down to understanding what behavioral economic decisions are moms making. And what we found were that there's some really granular details that describe that moms who have two jobs that have this decision where they can't leave that job to go into do the appointment, that between 20 and 27 weeks, when they miss those appointments, is when you start to see massive increases in infant mortality risk. The most important key thing was really, there was some low-hanging fruit. One of them was that African-American moms had an infant mortality rate of 18.6, let's just call it almost 20 babies died before their first year, versus white women whose babies were at 4.8 or 4.8 and went down to 4.4. Such an discrepancy, and it was attributed to access to care. But what they found was that if a mom was on WIC and Medicaid, she had a 50% drop in infant mortality. They also found that 20,000 moms who were eligible for WIC weren't on it. So you have this really cool way of sharing data between several agencies, which doesn't happen. We have to get to that point of sharing the data and being trusted entities in a collaborative manner so that you can really start to use this. And I know Stephen's got some examples where it's this shared data, this community-based approach that really does help solve some of this.
I want to go back to the reference that Andy made in her intro around the neighborhood health dashboard. Stephen from My Sidewalk and Blue Shield of California, in partnership, they have launched the neighborhood health dashboard, which is a free online tool for the public. So Stephen and Dee Dee, can you tell us a little bit more about what exactly is this dashboard? How do people access it? Who do you think the users are? And how does it fit into your health equity strategy?
That's a lot, Shruti.
We want to know.
I'll leave the data science magic to Stephen. But I will say that, what I love about it is it's super accessible, right? It's 100 indicators about community health, things like, infant mortality, like Michael was just talking about, things like life expectancy, which has also come up here today, poverty, educational attainment, the things that we need to know about, to assess the health needs of every community in California. And it's super easy. Like I said, you don't need to be a data science whiz to understand it or to get access to it. You enter a zip code or multiple zip codes, because most of us are serving multiple populations. And you will be able to look across those populations that you're trying to care for and understand their needs, and then design programs and also, focus your interventions and your investments on the places where the needs really are. What's amazing too is that there's about 80% of what's needed to create the community health needs assessment. The other 20 you gotta go out and get, as we've all been talking about here. But I think it's a lot. And even just a few weeks after we launched it, we saw over 700 dashboards created. So I think that that's speaking to the value that people are seeing.
It doesn't take a lot of exposure experience to realize that health needs assessments are an underutilized resource, and they're happening all over the country with relatively small impact. So how do we reimagine what that is and what the purpose of it is and who it's for and how it's used? And I think it's a big credit to Blue Shield to take this first step. So just to the point of access, you're not talking about just one data source, and that's where this gets tricky. We're talking about 20 different data sources ish, right? And that number is only going to grow. We're talking about hundreds of indicators and 1,700 zip codes, which is what we decided to use here in California. So to really make it personalized, you have to have a very simple way for someone to just filter everything that matters to them. And so that's where we've said, place is the primary piece of information that we need to know from people. It matters so much, and it also just defines who you are, where you live, who you relate to. And so by just getting an address from someone, we want to be able to give them a completely personalized view of the social determinants conditions in their neighborhood. And so that's really the driving force here, and the idea that we should be able to just take that address and give you the indicators that you need for that particular place in a matter of a few seconds. And so that's what we're doing here. But of course, the higher aspiration is that through personalization, through good storytelling, through making sure that this is the right data for the right person in the right moment, you're actually able to have a much a view of your social determinants that you can relate to and that you can really use. And so that's the goal here for the neighborhood health dashboards.
We know that data can be hard to access and acquire, hard and costly. So this is a great tool. Part of that, though, is also thinking about effective implementation. So the right workflows, processes that are essentially needed to do this in a strategic and consistent way. Can you talk about, maybe Michael and Andy, what do you think are some of the long-term benefits for making this upfront investment in figuring out effective implementation and scale, and including some financial benefits?
I'm going to talk about an important barrier, which is payment in a little bit, and I won't spend my time talking about that. But the long-term ROI to why you want to do this, in my estimation, whomever in the team environment that we're talking about figures out how to impact social determinants of health to bring down the healthcare dollar is going to win the gold prize at the end. This is the pot of gold that we're all trying to figure out how, because everything that we're doing in healthcare right now is not bending the curve. It just keeps getting more and more expensive. And we get more and more, great ideas that are costly, but they're not bending it. Social determinants of health, if we can figure out how to really change what's going on in someone's life to then bring down their hemoglobin A1C, that's it. And there's not going to be one way. It's going to be different and unique, and it really should be driven by the community. So while we might have access to this data, it's also public. So I would really hope that what we're doing is asking the community into the room and saying, where would we start? If we were going to start anywhere, which indicators matter the most to you? And start looking there. So I know it's expensive. I mean, I've heard this. I've been in the healthcare industry for, at least with the health centers, for 13 years. And investing in data and investing in systems is hard. And you need to know that there's an ROI at the end of it in order to do it. This one we don't know what it is yet, but it's going to be the thing that changes the entire health delivery system if we can do it. And to wait is just, one, it's immoral. We have to do this. Once you know that the data is there and it's telling you this, at least for health centers, this is our calling, this is our mission. We have to do this work. Maybe we step a little bit more lightly than others who are more well-funded, but we have to do it. And then ultimately, whomever gets there and starts unlocking the secret is going to be the one who has a massive financial investment or a gain on the back end of this. What would you add to that, Michael?
That's a great point. I will share that just like Steve and I have a 7-year-old who we were walking through some nature hike yesterday, and out of the blue, he goes, "Daddy, do you like being a doctor?" And I said, "Of course I do, but you don't see patients," because all he sees is Daddy on calls. So he's like, "What kind of doctor are you?" The reason I bring that up is because at that level of understanding is we have to get really basic. We overcomplicate things. I can't sit there and explain to him sort of all the things I do, but to Andy's point, what we really, there is a holy grail, and everyone's competing against to do that, right? And so that's why it's more than just the power of one. What I'll say is that from a economic perspective, an ROI, you have to see ROI in social determinants of health. It's hard to prove and articulate an ROI to a chief financial officer. And I say the thinking, because health systems are incredibly slow to innovate, is to stop thinking like Wall Street and really start thinking about what beyond that ROI. I know that the world works on dollars and cents, but for social determinants of health, there's a long-term, a short-term, and a mid-term annuity. And you have to think of it like that. Okay, what can we invest in now? What can we invest in long-term? And I'll tell you, all of the health plans and all your major health systems are investing in the long-term, mid-term, and short-term. And they're working on that right now through data access, but also through experience. And I think it was alluded to earlier that it is one thing to personalize an experience for somebody, but we have to really get to a point where instead of being paternalistic, as in you should take these meds and therefore bring your hemoglobin A1C, is to find out how people want to consume health, because people from all walks of life want to consume things the same way, just because they may have different economic backgrounds. So we have to get really smart about understanding why. From a cultural perspective, we know that the cultural DNA of a community is different, street by street, zip code to zip code. When you get to that sort of genomic level of understanding, you're going to be able to deliver the right type of care at the right time in the way that the person wants to consume it. And it might be that somebody who really doesn't have access to internet or a data plan, you'll have to go old school and really get somebody to knock on their door. And there might be somebody who's really sophisticated. And so there's different thinking around. The way we think about it is it's just person-centered health. I know it's a kind of an industry term, but the way I think about it, it's more of a culturally relevant personalized care where people get to choose and when they want it, how they want it, almost basically the Amazon experience for health.
If we can get a whole bunch of organizations who are committed to this kind of work around a shared data set, then we could have like a multiplier effect that's akin to what you see in other industries with place-based investments. And where consistent government funding and policy initiatives follow, right? And you end up creating like these regional innovation clusters, right? So it isn't just about one or two organizations benefiting, it's about everybody who is invested in, and I don't mean just from a monetary standpoint, but the people who live there and, work there, everybody's invested in seeing that regional innovation cluster become a growth center, right? And an engine for everybody. So I think if we look at it that way, and also the beautiful part of this is we don't need to waste any time creating formal partnerships to get this multiplier effect. We can just all agree to collaborate on the data, right? To get our multiplier effect. So I think that that's very exciting. And I'm hoping to see that happen.
Yeah, that's a great lead up actually to the next question. And, it reminds me, in this great state of California, we do not have a data sharing mandate, right? And so kind of going into that, what are some other industry and policy barriers that make it harder to do this work?
I'll jump in. The one that I would say that is the imperative to change is how we pay for healthcare. Healthcare is paid for on a for the preponderance of it is fee for service, especially in Medi-Cal. And that made sense. It's a logical system, but it furthers inequities because it is about the providers in power. And if you need something, you come to the provider in power and then a service is delivered, but it's also a service delivered that is incented for sick people. I do better I'm financially better off if people are sick and they come to me. If they're healthy, I'm not making any money. We have to change that paradigm, and we have to, I don't know that we're working right now. We've been working on payment reform with the health nurse for a long time. It's a really hard paradigm to shift. It's scary. Your whole outlook has to change from a one-on-one to a population health management. The types of financing mechanisms and how you manage populations and how you manage your finances all has to change. But it is, I would argue, one of the central barriers to really wanting our providers and our staff to focus on social determinants, because there's no money tied to our focusing over there. We're tied to the sickness. So we have to shift that, open up the doors, and then enable and start paying people incentives to keep people really healthy. And then we have more of a reason to invest in this data and work with our communities and get even more into it.
Yeah. And I think it's been mentioned a couple of times here about this idea that we don't have a statewide health information exchange, no mandate that everybody who is, an interested party and an accountable party to share that data in order to be able to have a complete patient history on the people we're trying to serve. So Blue Shield of California is working with providers, hospitals, other health plans to establish a system where all the elements, all the players in the care continuum are required to share that data in a statewide system. And we believe that this will help create a permanent, real-time, longitudinal patient record that's going to help us reduce care gaps and also be able to consider the whole person in their health journey.
Awesome. Thank you. Last question, you guys, before we move on to Q&A. I wanted to end with some practical advice from our panelists to attendees. So for folks out there who would really love to start using data in targeted and strategic ways, perhaps using some of the free resources mentioned here, keeping in mind some of the barriers that we have in industry and also some of these policy barriers, what is some practical advice for them in terms of what are the right systems that they should have in place to start doing this tomorrow and setting themselves up for success?
I think it goes without saying that, yes, do avail yourself of free tools and opportunities to collaborate, because I think we've all said it, we can't do it alone, nobody can. I think, so setting yourself up with this notion that you are not going to come up with some proprietary solution whereby you solve all of the health outcomes and access and equity. And I think, so setting yourself up also to be able to understand, I think this was brought up by a couple of the panelists too, understand what's important to the community, like what needles do they want to move, and creating mechanisms to talk to them and to check in with them to make sure that the things that we are putting into their lives, and that it's actually moving the needle for them, moving things that they find important. And then I think last point for me is be ready to follow the data, right? There's a lot of temptation to follow what's trendy, what executives are talking about, what's making news, but you need to be able to, if you're going to embrace the data, really, you need to be able to follow it, even if it takes you to a place where you don't currently have investments and your executives aren't excited about it.
DJ Patil, who's the first chief data officer for the United States, had a saying that data science is a team sport. And I really believe that to be true. Both internally, it takes broad perspectives, but it's okay to think about that externally too. Who's the external team that you want to be working with? To Dee Dee's point, this is just a small anecdote. We do a lot of work with citizen satisfaction data. And there's a question that often gets asked about how safe do you feel in your neighborhood? And the answer to that is often interpreted as a public safety concern. And when we've looked at that, we've seen actually there are much higher correlates with things like whether or not the person is employed, whether or not they're proximate to vacant properties. So really, this is an economic and community development challenge, not a public safety challenge, or at least not as strongly. And so that's just another way. And then like thinking about this through the lens of taking a holistic approach and working with the other team players that are out there, you can have a bigger impact.
I think this one is just easy. So here in California, we've got the Whole Person Care Initiative, which has been a phenomenal opportunity of bringing the concept being everyone who touches a high utilizer across the sphere, if you're a WIC, if you're a school system, if you're healthcare, coming together. But now that program has brought people together that had never spoken to one another. And now they have the same reason to do that, which is amazing. A lot of them are working on Excel spreadsheets. But now we have an opportunity with a new tool to get even deeper in together and see what happens. So that, I mean, one is just bring that tool into those meetings and we can see what amazing things can happen for those high utilizers. And a California example, but one that I think is probably replicable across other states.
Yeah, I'll finish up by saying, if not now, when, right? So as you sit there listening to this, everyone tends to go to the next meeting, just continue to talk. It's time to actually take action. And it might be pulling in different partners. But one thing you have to remember is to build trust with the community. If you do not build that trust, you're just another health system looking for data or looking for something to help yourself or perceive that way. And I think that's an important substrate that you have to start with. The other thing is data is only going to grow and there's going to only be more of it. So I would say don't try to be perfect. You need to be directional with your approach, but definitely get back to this use case, solving infant mortality, maternal mortality, substance use disorder. All these different components can't all be solved together at one. And it might be that a set of community-based organizations, a set of healthcare systems and or health plans will be together for one use case versus another. And then I would say, don't be afraid to think outside the box. And I know that's a cliche term to say, but often the thing people always say is, well, this is not going to be the next Uber or the next thing. Don't look for the shiny object. Just we're not talking about things that are new to health, right? We've known for years that poverty is a challenge and that it's an indicator of outcome. So it's not like we're trying to the data is going to help us understand something we already anecdotally know. But what was said by Didi, which is what I always say, is you have to let the insights drop and react to that. And you have to operationalize those insights. Don't just say, oh, great, we did a great data science look at poverty. Now what? Have a plan, have the right partners ready to go, and really just say to yourself, what can I do to make that difference? The time is now. It's not going to wait for the next pandemic. It would be amoral not to take action now, as was described earlier.
Well, thank you to the panel so much for that first structured portion. And now we are going to move into our audience Q&A. And one thing I failed to mention in the beginning, a shout out to Kiara, who is, if you'll notice, there is closed captioning and she is live typing away as we fastly speak. So thank you for making that possible. And I also just wanted to say, so we have over 230 people on the line right now attending. It's just incredible. I think it is inspiring how many people are interested in this topic and working on this topic. And we've had the attendees range from state, federal, government and policy to innovation ecosystem to health plans and systems. So also just a shout out to the attendees who are working on this and doing the actual good work. Okay, and with that, some questions. First question, what data privacy measures are taken to ensure HIPAA and California privacy law compliance when sharing all of these data elements between third parties?
Well, I can't speak for California, but I know in Ohio, for the state of Ohio, one, you needed a champion. So the state-led governor said, this will happen, we're gonna understand. But what we were asked to do is we signed a data use agreement with each agency, so Medicaid, public safety, schools, all of those, so that we were held responsible for that. Then there's these processes, and everyone on this call knows, and I'm not a data scientist, but there's ways to anonymize the data. There's ways to de-identify it, because you really don't need, you get to the individual and assign a number, but you're trying to just get directional. You don't need to get down to the actual member. That's a goal for everyone in the future. But right now, if you're just starting from scratch, it's really about getting the right data privacy protection. And then what do you do with all that data when you're done analyzing it? So there's got to be a process. In Ohio, the attorneys said, you guys will drain that lake. So it's sad because you take all that time building it and you could use it for other use cases, but that's just the way the world works. And I think that's, at the end of the day, there is, when we think of health equity, we also have to think of almost like an IRB or institutional review board, that what the data we're looking at does keep people safe. In the same way that an IRB does that for if I was part of a research or running a research project, we have a health equity practice that creates that framework so that anything, that there's no bias in the data, and that the data approaches in the digital and the technology don't negatively impact the population that could be subjected to, due to the lack of digital access, et cetera. So those are the things that you have to think through, at least from an example of what I've seen. Now, I can't speak for California.
Okay, this question is for Didi. I'm curious how these operations are integrated into the dashboard to provide a more community-anchored view of data.
Yeah, I think at this point, if you go out and check out the neighborhood health dashboard, you're seeing, I think the very first phase of this, right? Our first attempt at being able to take what is a lot of data from a lot of different sources and bring them together in a way that is just easy to consume. But what I hope that will happen as we go forward with, providing, what will, I hope, become sort of a data utility, you will see more of an opportunity for us to, let communities weigh in and share, sort of what they're seeing, from within the communities, and hopefully be able to also see a view from community-based organizations who are already addressing those needs. And but this is phase one, and so let's hope we get richer as we go.
So how do we reach the people in need outside of the clinic setting if we know so many aren't getting their preventative visits done and are not talking to healthcare providers?
this is a great question. The idea here is as use the data to understand the population, but then now it's just one thing again to understand either a heat map or what people's needs are. But now this is where the community-based organizations start to really get leverage. This is where your community health workers start to get leverage. This is where your trust with even your barbershop. The longest relationship I've had in my life is actually with the guy who cuts my hair out of St. Louis. Started at residency and all the way through the time I moved from St. Louis. His name is George. And I joke about that, but he has seen me go through a divorce. He's seen me get through married, and he is somebody I talk to and trust. And so we all have those people. We have people in our families. And LA Children's are using the Pomodoro model, where they're trying to use a digital tool to reenact what that sort of trust-based, like me, Tia, who's going to help me in understanding that culture, and that's how they, from a Hispanic perspective or Latinx, that how they consume and understand health. There's a literacy perspective. So I would say that it has to be granular from a perspective that you are able to not only just understand the population trying to help, but then really provide those resources in there. A large health plan in California is exposing, in the same way that Stephen's group is doing, this information, because if you really go upstream and really impact the community and try to make the community healthy, and then it's not just a matter of saying, here's a Rolodex of places you can call. It's actually tracking, and you're going to have to bring in either technology or have an understanding to what Andy was talking about in the cost perspective. You have to close that loop. If I refer 1,000 Mike Petersons to a food pantry, I need to be able to understand that 1,000 Mike Petersons went to the food pantry and it had some sort of clinical impact in his either diabetes, his obesity, or whatever it is we're trying to measure.
There's something nice also just about making this available, making the data available to agencies that wouldn't have it otherwise. I was talking to a fire department in Indiana yesterday. They had this same kind of idea that they were going to democratize their data. They were going to make their risk available, and they're presenting it to council, and somebody from Meals on Wheels is there, and they're like, oh my gosh, can I use that to help target where we're going to be doing our outreach? And I think it's just a good example of how, by putting this out there, you can reach people that are outside of the clinical setting that are already working in those communities.
Yeah, I think COVID's open. I mean, again, for us, payment really is a barrier. It's preventing people to go outside of their walls to go find people who are not showing up. But COVID, because we're needing to protect our communities, we need to go out and test, and especially in communities that they're being overly exposed, and they also don't want to test because they're afraid of missing work or for whatever reasons that they're not interested in that. We've seen our health centers really trying to bend into the community to try to figure out where they are, right? So they've been going a lot to churches to just figure out, so what's going on at the church? How can we start a conversation about trust? And any local, and especially like in specific community groups, I was hearing something about trying to bring different AIDS education to a Somali group, and it required starting to meet with the elders. There were no meetings that the clinic could just start having, and then they had to ask how to even begin the conversations. But COVID, I think, is a good example of why we need to bend, because we're not going to stop this pandemic unless we really get everybody back into the environment of at least some healthcare access, or at least knowing that there's a clinic around the corner that you can get tested, the resources to provide and help you. The vaccine is going to be a really big challenge. It's going to take a lot of trust and a lot of touches to get folks who are like, I am not taking a federal government vaccine. Very good reasons to be suspicious about that. I'm not endorsing not taking the vaccine, but understanding and empathizing with that, we need to start touching and reaching out and working with anybody that we can. So I would have to say COVID is the reason why we need to start bending in, even if there's no immediate financial return to doing so. It's going to help the economy come back to life. It's going to help normalcy come back to life. It's going to prevent death. So I would argue that that's the way, and not to assume that because the healthcare, like that people trust you because you're a healthcare provider. They trust the mother down the street. They trust somebody else. So you just have to learn who those people are and start connecting with them.
So kind of leading into that, it's a great segue to this question, which is, how does the dashboard play into efforts to address health equity? And is there relevant legislation or executive action from the governor needed to address these disparities we've seen both in COVID as well as the broader healthcare access challenges?
So I wish there was an action that the Governor Newsom could take that would solve all of this. I don't think that there is. I think we probably all, I'm sure you know, Kieran noted one at the beginning to say that, you know, systemic racism is a public health crisis. That's, you know, it's starting to change. It's starting to leverage the energy that we have in this pandemic, which is not just about the pandemic, but systemic racism and health equity, and to leverage that excitement and to move. And I hope folks, I mean, who are listening, we're feeling the excitement that a lot of us have, because I'm going to guess most of us on this panel were driven into our fields because of justice. And we've known for a long time the things that were impeding progress, but they haven't been tangible. And there is a moment right now that I hope that we are all feeling, and feeling the imperative of leveraging and not letting perfection or a certain policy get in the way that it has to be this way. We just have to keep moving forward to make this happen. And I would argue, you know, I really want to see payment reform happen. I want to have it for all the providers. I want to flip that schema over. I'm sure that the schools probably have another one, a public health crisis for racism. There's so many that are necessary, and not one of them has to be done first or is the perfect one. I'm a big fan of throw the spaghetti on the wall, and we're going to follow that one. And maybe we figure out that that one didn't work at all, but we learned so much in the process, and that's good. So there is absolutely no wrong thing to do in this process, just to move with, I would say, with an open heart. I think having a big open heart and empathy is central to this work, because there's a lot of pain associated with it. But if we do it with a, you know, with common purpose, in collaboration, we can only make the world better.
So not to beat it again, but I will say that, you know, we do need that mandate for the statewide information exchange. And it's not just so that we could know, you know, all these things about people, but it is so that, you know, to your point about being able to think about how we change the way we pay, I think you're not going to have a full understanding of what it is we need to pay for, and the things that are creating value by, you know, really driving health outcome improvements and really driving toward closing health equity gaps, until we can see the full journey, the places they went, the services they received, and also how, you know, how it all turns out, right? So I do think that that is something that we can do, that statewide, you know, health information exchange.
And a good follow-up to that question, somebody asked, at the local, state, and federal levels, what can we do to ensure support at these levels? You know, what can folks advocate for? How do they do it? Any suggestions?
I would say, you know, at least from a health equity perspective, things are local, right? So I would, you know, it's been described that, you know, what, you know, is Governor Newsom going to just say tomorrow, thou shalt share data? If you're going to wait on the government, we will have this conversation 2 to 3 years from now. What has to happen is there has to be an organic, just like Blue Cross Blue Shield, California is doing, which is they're not sitting around waiting for somebody to say, hey, finally, we've got some data you guys going to share. You have to start organically. If we don't do it, you will be the next Blockbuster or the next Kodak, because the market is moving fast, and health plans, as much as they try, making big, bold decisions are really challenging, right? Because they have to think of all these different things. But the ones who do make a big leap, so there are some that are making a big bet on everything, all the care, the model of care, to Andy's point, the model of care is going to be at home, right? So payment model for that, how do you think that through? We're going to digitize everybody's IoT devices at home and get data from that and try and keep them from coming to the hospital. We're going to flip that whole model of care, that we're going to go see Dr. Peterson at the ER. No, we're going to do A, B, and C, right? And so as that model flips, especially around mental health, we really have to address that piece. Those things are going to change. So back to the question is, one, it's got to be a voice. People have to have a data-driven mindset, and data does inform policy. We saw right away in the pandemic that the policy around telehealth went out the window. Permissions were given. I could have had patients on FaceTime or WhatsApp, and it was legal and it was fine. They did that in a flip of a switch. So it's not that it's not possible. It's that there has to be an impetus to do that. And it's usually done either through a crisis, which we don't want to wait for the next crisis, or through data-driven pushes that the government says, oh, that's the way we should do it.
I'd also say, I mean, health equity is massive. It means so many different things. And for folks who are motivated and maybe they don't work in health equity, but they want to do something, I really think it's just about, I mean, there's statewide organizations who can connect you. There's a few here, but there are always organizations in your community who are doing something. And you can look it up I bet like connecting to the city, there's lots of different ways to get involved. And then that will open the door because those organizations are connected to other organizations that then just open the door for your involvement. And there's so many places that want you to know what they're doing. There's not, you just have to figure out which door to walk through to start how much information do you really want. Or you connect to national organizations that you know are doing really important stuff, like an ACLU, and then there will be local chapters of so many of these national associations too. So I think it's just, you know, getting on the computer and putting in a few keywords and then seeing where your journey leads you. And again, it's like spaghetti on the wall. Even if you end up at an organization you didn't like, you're going to find one that you do like in the process of exploring that one other organization.
I think that the clearly just the public's ability to translate data and data information has been transformed over the last 9 months. I mean, everybody's talking about things that we couldn't have imagined. So small silver lining. I'd say even just looking at the dashboard and then finding like your life expectancy data set or something like that, and then asking your local electeds or your local municipality about why that is, and man, that doesn't seem fair, and what are we doing about it? I think that can also have a pretty profound impact, because all of our local communities are little experiments waiting to happen, and if we can provoke some of them in a good direction, I think we'll see some good results.
To Didi's, I think Didi raised a good point talking about you have to listen to the community. I'll give you a quick example. In North Carolina, a health system wanted to help a community, and they sent their lead strategy person in. And what that person didn't do was say, how many people have died? We already know who has diabetes, and sort of come up with a paternalistic plan. They just sat and brought the sheriff, brought the pastors, brought all the community leadership, and just had a conversation, just like a round table, almost looked like a self-help group. And what he heard was that the community didn't want the health system to help them with anything except to build a community garden. And I think that that is a profound story, because that is how we have to really think, is that we assume because people are living in abject poverty that if we provide them all the free things, that's what they're going to use to help themselves. We have to understand the importance of stigma, the importance of what it is people need. But this community garden, they were able to donate a gardener. They were able to donate things from Home Depot, Lowe's, and they started building. And then after they got the community garden started, guess what they did? They said, hey, sir, we actually do want, we know about 15 people that have this problem. And then they started, so what does that do? It starts to build trust, starts to build a relationship, which is what all of us on this call and everyone on the webinar do, is at some point, the work we do has to do with a human interaction, whether it be a patient, a community-based organization, but there is a spark that happens, and that interaction is what we're trying to solve for. We're trying to increase more sparks for those who have needs so that they can help themselves, but also that we can provide the right care and right resources so that they can do this on their own as well.
Yeah, and Kieran, I see that you're back on too. Given CPAN's targeted focus on this, I was just wondering if you also have any thoughts.
Well, just to say, I know there was a question about racism as a public health crisis, which I think is sort of overarching a lot of this, because I think what we know is that when we look at social determinants and we look at healthcare, institutions are doing what they were designed to do, right? And so I think to Andy's really good points about payment reform, we do need really big transformation here in order to really solve for these things. And there are small steps we can take along the way, and things that all of us can do each and every day. And so I think it's important to hold both of those things as true at the same time.
Awesome. And so last question, just because you just mentioned this, talking about payment, the codes. Do we have a complete set of codes per CMS that include social determinant of health metrics?
I know Andy was going to go. I'll just quickly say there's a project called the Gravity Project. They're trying to create ICD-10 codes for this. What a lot of providers and systems are using are Z codes, but they're not all standardized. So you're having some health plans approve this health until you get to a level where everyone's standardized the same thing. So if I'm a clinician and I spend 30 minutes, it's not that I need to get reimbursed for it. We need to track this stuff. So there's that piece of it. So that we understand the type of work that's going out there. And really, in the same way that the work that I do is to prove that there's a need out there. It's not the healthcare system that's going to solve social determinants of health. They're a part of it, along with people who represent all the entities on this call, but government has to be a big piece of it, and other elements of government have to be a piece of education, all these things. So I would say that the coding does have to be standardized, and there's an effort towards that.
Yeah, I guess the only thing to Michael's point, the simple answer is no. We've been struggling with this for a long time in the community health center industry. But I also, you know, in the era of think outside of the box, healthcare providers, and I'm going to guess everybody else in institutions, hates coding and is bad at it anyway. Like, most people are really bad at it. So there's a big push, like when we're saying, well, let's track all the stuff that we're doing. They're like, so we have to go more volume. We have to do, all I'm going to do then is be tracking things. So I do think I have a big question. Should we be tracking everything? Is that really the way to go? Because there's a lot of pushback, and we don't want the exercise of doing the good work and then accounting for it to actually backfire on us, and then nobody wants to do it anymore. So and this is a call out to the public who's listening, who can figure this out so we don't have to code everything and yet we can still do really good work? What are we going to do about that? But at this point, we are trying to figure out the coding issue, which is important, so we can value it. But that's a kind of an old school way of thinking about it. Maybe there's a new school way. I don't have it, but I would just put it out there, and a lot of people would be really happy if we can move away from the coding.
Well, we're at time, and what a great way to end with a call to action, right? So thank you all for joining today. Thank you to the panelists for your targeted insights and recommendations, for the attendees. Thanks, everybody, and enjoy your weeks.
Thank you, everybody.
Bye.
Bye.